Hold on.
Sorry, guys.
We'll sort it out.
Okay.
Sort it out soon. Well, I will. I'm not going to do it personally because I have no idea what we're doing anyway.
Okay.
Are we ready to go?
Ready to go.
Yes, that's a very nice idea.
I think this is still. You can't minimize that.
You're not. Oh. How do we see? Cancel.
We're trying to get rid of this bit here.
So you might just have to do that with it. Oh, hang on a minute. Why isn't there a thumb button there?
There's no minimize thing, is
Yeah, you just have to do that with it. Cool. Okay.
Is that going to work? Are you happy?
Yeah.
Thank you very much. Thank you very much for coming, to those of you who are here, and thank you to whoever is joining us online. Yep, Kerry has just asked me to say that, can you let her know by raising your hand if you can hear and see, or see and hear, whichever. And at the end, when we have a question session, if you would like to ask a question, please raise your hand to Kerry and she will direct you to us. It's a pleasure to welcome you. Several thousand years ago, Hippocrates would have said that medicine is an art. Life is short and the art long. But of course what he meant by art was not art necessarily, it was the esoteric technical skill of the medical profession. And that has been a persistent use of the word art within medicine. If you look at David Weatherall's book, The Art of Medicine, it's still really about those the particular skills and techniques that a medic brings to his practice. What we are talking about here, and what is at the heart of some of our centre work, is something quite different. It fits with our WHO work, but also the Wellcome Centre. An interest in the ways in which culture, cultural contexts, shape our health. As part of that, we are interested internally and also working with external partners to think through how arts benefit health and well-being, how artistic endeavour, artistic engagement, visual representations and other artistic creative representations can help shape health services, but also help shape our own health and well-being. We have three fantastic speakers, and it's a great pleasure to welcome them. I'm going to introduce them in turn. What intrigues me, I think, about when you, some of you will have seen the abstracts of their talk, is the ways in which they talk about art and health, but they also talk about the processes of participation and engagement and their relation to health in various ways. And I think, again, it's a key feature of some of our work that we want to look at participatory research, engaged research in a way that benefits our health and well-being. Our first speaker, we've asked them each to speak for 15 minutes or so. We will run the talks together and they will come together to answer questions individually and collectively. Our first speaker is Daisy Fancourt, who is from the Department of Behavioural Science and Health at University College, London. Her work over a number of years has been on arts and health, but what is particularly striking about the current work is its use of quantitative cohort data to chart relationships between art, cultural engagement and health, and to think about the ways in which art, cultural engagement also link to various physiological markers for health and well-being as well. So there's a whole range of questions about the use of big data, the tracking of art and cultural engagement, and impact on health and well-being. Daisy, I will let you.
Thank you very much, and it's a pleasure to be speaking today. It's really great we're hearing so much now about the way that the arts can be used within health. But this actually isn't a new conversation. The earliest evidence that we have for the arts and health is from nearly 40,000 years ago. What is new, though, is that in the last couple of decades, we've seen an increasingly strong body of evidence as to how and why the arts can affect us. So today I wanted to talk through some of the studies that I've been involved in this sector, particularly focusing on 3 different types. The first of which is studies that have looked particularly at the mechanisms of how the arts affect us, focusing in on different biomarkers from laboratory studies. The second is looking at a more applied approach, so looking at how the arts interventions can be developed for specific health conditions. And the third is taking a population approach, so zooming out even further and thinking how arts engagement in everyday life can affect health and well-being. I'm going to be looking at some of the intersections between these different types of data. So one of the early areas I got interested in was how the arts might affect biomarkers. And one of the early papers I wrote was about the use of music and how it can affect different hormones, cells, and proteins in the immune system. And actually, I was really surprised when I started this work that there had been so many previous studies. I found over 60 different studies carried out from 22 different countries. And they'd shown that been a broad range of different biomarkers that had been shown to change in relation to either listening to music or playing music. Now, there are a couple of interesting things I found from this body of evidence. The first of which was that most studies had tended to imply that music could in some way resonate directly with biomarkers. So there's this direct pathway between music and a biological change. However, I felt this was slightly at odds with research from 2 other fields. So within music psychology, research had been increasingly showing over the last 2 decades how music also can affect our brains. And so we were looking very much at this psychoneuro intersection. And from the field of psychoneuroimmunology, what we know is that internal thoughts and external events in our environments can have both a psychological and a biological effect on us. So I felt instead of it being about this direct relationship between music and biomarker, the psychological and neurological processes were really key. So this provided a route that was much more like this in its approach. The second thing I noticed was that a lot of previous studies had spoken about music as though it was a single entity, whereas in fact music interventions could involve the music itself, but also physical responses, social interaction, and also personal, emotional responses to the music. And I felt if we're starting to talk about music or the arts more generally, we have to recognize they are complex interventions with many different interlocking components. So on the basis of this, I've undertaken a number of studies looking at music and biomarkers. And I want to share the findings from a couple of these, starting first of all with stress hormones. Now, there are many different ways by which stress can affect us biologically, different pathways involved. 2 of the broad ones we hear a lot about are the autonomic nervous system, which is a system of nerves running from our brains across our whole bodies, including different organs such as the heart, and affecting glands such as the adrenal glands on top of the kidneys. And the other is our endocrine or hormone system. And this has different pathways, including the HPA axis, which is where signals from the hypothalamus in the brain can lead to the release of hormones into our pituitary glands, which can then travel via the bloodstream to our adrenal glands, hypothalamic pituitary adrenal axis. Now we see a range of different biomarkers then being released in response to these effects, including catecholamines such as adrenaline and glucocorticoids such as cortisol. And I want to show you some findings about cortisol, which I've looked at in relation to music. And I particularly ran some of these studies to look at this psychoneuro intersection and see how that might be affecting biological response. So one of the studies I ran was looking at singers, and I worked with a choir run by the composer Eric Whittaker, and we decided to have singers perform the same music but in 2 completely different psychological contexts. So on the first evening they sang an hour's worth of music but with no audience, and then the next evening they came back and sang the same music in front of 700 people. So a very different psychological context. And when we looked at their anxiety ratings, unsurprisingly, we found that in the low stress condition, they hadn't really had any change. They hadn't been nervous and it hadn't really done anything psychologically to them. But in the high stress concert situation, they were much more stressed at the beginning. But across that hour, we saw a reduction in their anxiety levels. But now this is what we found in terms of looking at stress hormones, including cortisol. Very different profiles depending on whether they were in the low stress or the high stress conditions. Now I'm going to crudely combine those graphs so you can see the psychology and the biology together. And there are a couple of things to note. First of all, we actually didn't see an exact matchup between psychological and biological responses. And in many ways, this isn't that surprising because there is a lag time in the production of biomarkers. So we don't always see them tying up neatly. But what is interesting here is that we see completely different biological responses in the two different contexts. And I think this is an important thing to note because it suggests that it isn't about a specific relationship between certain types of music and particular biomarkers. The context in which we experience music profoundly affects our response to this. And I've done some other studies since looking at other ways that we can receive music, including going to concerts, where we found actually almost identical responses listening to classical concerts and pop concerts. Again, because it seems like the environmental context is very much the more important thing here. And I've also shown this isn't just limited to biomarkers such as cortisol. We see it with other biomarkers involved in stress response, like progesterone and dehydroepiandrosterone. I've also got interested not just in the stress response, but in the wider immune response that we can have to music interventions. And I've particularly looked at cytokines as a biomarker. So cytokines are tiny proteins in the immune system, and they act a little bit like messengers, essentially communicating between different cells. Now, cytokines can be suppressed by stress hormone activity, so we often look at the two together. Now, I've run several studies where we've looked at how these can change in response to different music interventions, and one of the things we looked at was an hour of singing, an activity that lots of people do. So unsurprisingly, when we look at psychological responses to singing, we found that across an hour, people feel much less angry, stressed, and they feel much happier, more energetic. The kinds of things that we're probably all used to feeling ourselves when we engage in singing. What we found alongside this was there was really active biological response to singing. Now, one of the things we found was that these cytokines that are labelled on the graph, a lot of these increased across an hour of singing. And this essentially shows a general activation of immune activity. We also found that this was linked in with the reductions in cortisol that you can see as well. There seemed to be this reciprocal relationship between the two. Something else we found as well was that the cytokine response was very much linked in with emotions. So cytokines can broadly be classified as either pro-inflammatory, so they promote inflammation, or anti-inflammatory, so they reduce it. And what we found was that actually across an hour, the people had the greatest improvements in their mood in a positive way, had the lowest levels of inflammation by the end. And I'm going to come back to this inflammation later. And it seems that there are several reasons why activities like singing can be beneficial in this way, one of which has been shown by some studies in America, where they've found that there are 3 particular components that need to be included in an intervention for it to be able to affect positively immune responses. And as you can see from these 3 things, emotional expression, social support, and a kind of optimistic outlook, these are things that we get very naturally from being engaged in music and the wider arts. But all of this very basic science knowledge is only really helpful if we can look at it in relation to an applied clinical approach and see how we can develop interventions based on this knowledge to support health conditions. So I want to mention a couple of projects that I've been involved in where we've been trying to do this, particularly focusing on mental health. So one of the projects that I've worked on was looking at drumming for mental health service users. And this recognised that if we're trying to help people recover from mental health conditions, it's important that they're doing things in their communities that will develop their social support networks and help to give them a sense of purpose. So we got people involved in either 6 or 10-week programs of group drumming, 30 people drumming together. And we also compared these people with those who were not involved in drumming across the same period, but had the same kinds of mental health conditions. And what we found was that the drummers actually had significant improvements in their anxiety levels, their depression levels, their social resilience, and their well-being if you compare them with the non-drummers. So the dark lines here show the drummers. What was particularly interesting was at the end of the 10 weeks, we then stopped the drumming program and we left everybody for 3 months. And we checked and no one was able to do any more drumming because there was none available where we were working at the time. And then we measured everybody again 3 months later. And what we found was that all the results that we'd noticed in those 10 weeks are completely maintained across the following 3 months. And this is really promising because it suggests it's not just about in-the-moment effects. Taking part in these programs can, at least seems to lead to these wider, longer-lasting benefits. Also, this tied in very much with what we found from the more laboratory-based studies, because we also looked at the biological responses across this program. And we found that in individual sessions of drumming, people again were having these reductions in stress hormones and boosts in immune activity. And the blue lines here show the first session of drumming, and the red ones show the 6th session of drumming. So the effect seemed to get stronger as people were more involved in these activities as well. We also found across the 10-week program there were reductions in inflammation. And this is significant because around 30 to 50% of people with depression have got heightened levels of inflammation in their bodies, in their immune system. So actually seeing this reduction in inflammation alongside the reduction in psychological symptoms added to our understanding about how drumming was affecting depression. I also worked with some colleagues who specialise in qualitative research, and they undertook some studies to try and understand why drumming was having these benefits. And they particularly found these themes clustering around the mutuality of drumming, the creativity of the activity, and also the fact they were learning something and gaining a new skill across the programme. Another project I've been involved in is looking specifically at postnatal depression. Now, this affects around 30% of mothers in the UK, but many mothers don't want to take medication because they're breastfeeding, and they can also be concerned about accessing psychological support because of a lack of time or even a perceived stigma. So we ran a study looking at whether community activities could support the mental health of these new mothers. So we recruited people who specifically had postnatal depression post-birth, and we randomized them into either a 10-week singing program with other mothers in exactly the same situation, or we randomized them into 10 weeks of usual care. But we also had this comparison group in the middle, and this was a group that had 10 weeks of social activities, identical to the singing group, but without involving music. And this is because we wanted to see, is it the music that's having the effect, or is it just that music is a social activity? Now, you expect postnatal depression to get better over time anyway, but we wanted to see, could we speed up the recovery to make it nicer for the mothers, but also reduce the chance of it having any adverse effects on them or their children long term. And what we found was that the singing group had a significantly faster recovery than the other groups, recovering about a month earlier, which in the lived experience of a new mother is a long time. And we found this didn't happen even for the comparison social play group. And again, we found that there were some specific links back to more of the basic science studies, including finding that singing led to increased levels of mother-infant bonding that we didn't find in non-singing activities. And it also led to greater reductions in stress hormones as well. And again, some of my colleagues looked at the qualitative approach here, and they compared the singing and the social group. And the blue boxes here are what we found in both activities, but the pink boxes were only found in the singing activity. And these seem to be key to why it was that singing specifically had benefits. And they particularly clustered around the emotional benefits that you got from singing. I've only touched on a couple of ways that music and other art forms can affect specific health conditions, but I have also published a book this year going into this in a lot more detail, including looking at things like how music can help premature babies gain weight, how dance can help Parkinson's patients to walk, and also how the arts can be used with medical training for doctors as well. But I want to just talk about the third area now, and this is zooming out again to actually look at the everyday arts activities that we might do in our daily lives. So these aren't things where we're doing it for a health benefit, but they're things that might happen to have health benefits as well. And it's important to look at this because a lot of studies that we do work with quite small sample sizes, maybe a few hundred people. So the program of work I've started this year, funded by the Wellcome Trust, is to look at using cohort studies. So these are big national data sets that contain tens of thousands of people. And they are nationally representative, and they track people taking psychological, biological, medical, social, educational data every couple of years of their lives. So they're incredibly rich data sets. And some of these are run by UCL, and they actually contain a number of variables on arts and cultural engagement. So they're a really valuable asset, I think, to be looking at this topic in more detail. Now, with cohort studies, because you're tracking people, you're not actually designing an intervention, so it's not a randomized controlled trial. So there's always a little question about the causality here. Are we just observing these changes, but are they actually causal? However, there are so many variables in these data sets, you can build some really sophisticated models. So I'm about to show you some results looking at cultural participation and cognition. But what I can show here is that there are so many other factors that might actually explain why engaging in culture might affect your cognition in older age. For example, educational attainment, if you've had more education, you've got a lower risk of things like dementia, and you're also more likely to go to museums and galleries. But what you can do with these big data sets is you can build all of these potential demographic, health, and social confounding variables into the models. And you can see whether there's still a relationship showing between arts and culture and whatever your health outcome is. And with the benefit of large sample sizes, you can actually have enough power to do this. So one of the things I looked at, as I mentioned, was cognitive function in older age. I wanted to see, we hear a lot about the arts and dementia, but if you're just engaging in the arts generally, does it have any benefits on cognitive decline? Now, as it happens, about 40% of people, 40 to 50%, either go to galleries or museums, the theatre or concerts, or the cinema at least once a year. But only between 5 and 8% do this on a monthly basis or more. So actually relatively low numbers on a regular basis. but actually research is suggesting that people should do it more often. Because what I found was that attending galleries and museums was associated with better memory 10 years later. The more you attended, the better your memory was. And we saw this as well for theatres, concert and operas. And this was even when we took account of their baseline cognition when I started, and all of these other factors. So we were still seeing this relationship between cultural engagement and better cognition, so a lower cognitive decline over a decade. And we also saw this in relation to executive function as well, this relationship here that more cultural engagement is linked in with better cognition. I've also been looking at another hot topic, which is well-being, and we hear about this a lot in relation to arts and culture. But in fact, well-being we often talk about as though it's one construct, when in fact it's multidimensional. So we have hedonic well-being, which is much more about the pleasure that you get from things, versus eudaimonic, which is more about your life, the more you get from your life, basically. So within hedonic well-being, we can have experienced well-being, and that's to do with positive aspects or negative affect, things like symptoms of depression. And we also have evaluative well-being, so how we actually judge the quality and satisfaction with our own lives. And within eudaimonic, there are different aspects, for example, how much control and autonomy you feel you have in your life, and also things like self-realization. So I've looked at this, again, across a 10-year span. This analysis is about 3,500 people, looking at whether people who are engaged in arts and culture have better well-being 10 years later. Again, even when you control for all these other variables. And I found very different profiles for different types of arts engagement. So for going to theatres, concert or operas, we found that these people had higher levels of positive affects and lower levels of things like depression symptoms. And they also showed much better eudaimonic well-being, so more control and autonomy and self-realization in their lives. When we looked at well-being, with museums and galleries, we actually found a slightly different picture. So no clear effects on negative effects, and some slightly weaker effects on positive affects and control and autonomy. But we were seeing effects quite strongly with self-realization still from going to museums. Unfortunately, the cinema doesn't have any benefits from well-being. But I think it's interesting that we can now start to talk about the arts and well-being in a more sophisticated way in terms of what aspects of well-being are actually being affected and how different types of engagement can affect those different types of well-being. And one of the reasons I think it's important we do this is to do with many of the reasons people are using health services. So about 20% of GP visits are for non-medical reasons. And this has a cost associated, which is the equivalent of the salaries of 3,750 GPs per year. But what we're now seeing is that over 400 general practices nationally are trying social prescribing, where when these people come in with things like loneliness or low-level mental health, we can actually pass them on to community services that are probably better placed to provide support for those people. And the economic evaluations from this are showing that for every pound spent, between £4 and £11 can be saved for the NHS. And in fact, some of these schemes don't even cost money. They're more about signposting people. The problem is we haven't so far known what kinds of activities to refer people onto. But hopefully with these cohort database approaches, like I've shown you today, we can start to identify which broad types of cultural activities and community engagement can have which types of benefits, and hopefully move more towards a precision social prescribing model. So I just want to finish by giving a few references in case you're interested in following this up. I've been working very closely with Arts Councils, Public Health England and central government, and they've been helping to refer research questions through for me so that I can actually analyse the things that are most relevant at the moment to policy and practice. And we're also getting a lot of steer from things like the All Party Parliamentary Group. They've produced the results of their 2-year political inquiry in July in this report for Creative Health. And this has got a number of recommendations that are now being taken forwards within government, within arts councils, local authorities, and also grassroots arts organisations. And if anyone's interested in following up from a research perspective, I've also recently launched an early career research network, which is aiming to bring together people who are working at this intersection of the arts, humanities, health, and medicine. So if you're interested, you can see the website to find out more. So overall, I think that it's really exciting we're hearing so much discussion about the arts and health now. I think it is critical that we continue to look at these different types of evidence, particularly zooming in between the very specific mechanistic studies that can help us to understand why the arts affect us, but also zooming out to applied studies in clinical settings and this population approach. And hopefully this will mean that overall we're in a position to make the most of the vibrant cultural sector and the cultural assets that we have in the UK. I just want to thank my colleagues and funders. Thank you very much.
Daisy, thank you very much. A fantastic set of discussions and provocations there for many of us, I think. And we will come to questions later. Ruth, are you next? Thank you. It's now a pleasure to introduce Ruth Cohen, who comes from an organisation, arts and education organisation, Daisy, working particularly with young people to encourage engagement with music, and through that to enable social change and health-related change as well.
Hang on a second. And that one. That's your one, isn't it? I think it's this one. Yeah. Brilliant. Thank you.
See the one.
So that's coming next.
Yeah.
And it's these ones, is it? Yeah, brilliant. Okay. Hello. Yes, my name is Ruth Cohen. I'm from Daisy. We are a local arts education partnership organisation. We're a charity. Just to give you a sense of scale, we have a range of about 80 artists that work with us, and we place the artists in various projects with young people. We work all across Devon and Torbay, and we're based just down the road in Exeter Library. We work across a range of scales. We will have sort of one-day projects where an artist goes into a school and does something small, up to sort of 3-year commissions. We recently ran a commission from Devon County Council, which was about supporting wellbeing in communities across all 31 learning community areas in Devon, looking at young people, people with disabilities, and older people. And in contrast to what Daisy was talking about today, which was really fascinating, I'm just going to talk to you about a couple of projects that we've been running where we have a particular focus on positive wellbeing outcomes and specific mental health outcomes for young people. And it is very qualitative what I'm talking about today, not at all quantitative, and I just would like to drill down into some very specific things that we have been told by young people about the work and why it has benefited them. So the first project is called Artifact, which is specifically about working with schools to put creative support groups in for young people. And this came about because Devon County Council were putting out a commission that was about assisting schools to help young people's mental health. And the arts, or any kind of positive participatory activity, wasn't being talked about as part of that package for young people. And we really felt it was something that needed to be part of what was offered as part of a menu of provision for young people's support. So this project, we worked with schools and put artists in to run support groups for 10 weeks. They worked with small groups of young people who were not currently accessing CAMS support, but had either self-expressed concerns about their own mental health or who had come to the awareness of staff as having mental health concerns. We worked with artists who were particularly interested in young people's mental health and who had some training. We worked with mental health professionals to train them and also to set up the remit of the groups that they were running. These were not medical interventions. This was not art therapy. It was creative participation that would allow young people to support their own mental health. So we drilled down to some specific outcomes that we felt would indicate positive mental health for young people. These were about self-confidence, trying new things, joining in, understanding how to affect change for yourself, and also how to seek help, and feeling positive about relationships with peers and your setting, and wanting to do more in the future. We collected data through benchmarking, midpoint analysis, and final point evaluation, and interviews with students, artists, and setting staff. This was a project that was actually we found incredibly difficult to do quantitative analysis on because of the small data set and how very varied the participants were. So this was one of the settings that we worked in. It was a primary school in Newton Abbot, and these were with quite young children who teachers had identified as having very low resilience, even at that young age, and were very struggling with anger management and felt were at risk of developing mental health. And they took part in individual weekly piano lessons, and from the outside these looked just like a piano lesson. They learnt to read music, they learnt to play the piano, but the setup was very particular in that the whole thing was structured around encouraging participants to feel relaxed and to have individual attention from a teacher and to take risks and learn how to make mistakes. There was a lot of encouragement and a praise for success and encouragement to try again, and the lack of exposure to other peers and being able to do things in a safe space without peer judgment seemed to be something that many of them needed. This project had really notable gains in resilience across the groups. I don't know if you can read the quotes very easily. There's quite a lot of quotes, but a lot of the young people said that they felt now more able to make mistakes, to try something because they were not so fearful of getting it wrong. This seemed to transfer out of the music lessons into the classroom and into their broader lives. Another one of the settings we worked on this project was a secondary school where we worked with students aged 11 to 14. Again, these students had self-identified as having emotional and psychological concerns for themselves, and teachers had also identified them as needing extra support. They took part in a series of printmaking sessions across a term, and for this group, again, confidence and resilience seemed to be a real gain. In early sessions, it was very obvious how reluctant they were to try new things, to put themselves forward, to do things in front of a group, and this improved markedly across the time. It was felt that printmaking was a particularly beneficial art form for this because of the fact that there is no clear necessary endpoint and you can make multiples and try things again. It seemed to be something that the students found very relaxing and felt able to kind of push themselves forward with and without fear of failure. The students were very well supported by the staff in this setting, and this seemed to be something, the setup of the environment seemed to be very important. The students were given hot chocolate and biscuits by the staff. They went into a special room. They it wasn't just an classroom where they got shunted in their timetable. They were felt like they were selected to do something special, and they felt they were valued by that. And in fact, in another setting, there was a very interesting comment from some students who felt they'd been valued by the fact that they had nice art materials to work with, that the artist had gone to the effort of buying nice paper and quality materials, and they felt a sense of self-esteem through that act. This support from the staff meant that the students felt in the long run much better sense of connection to their school, and they felt better supported by their peers and by the staff. Interestingly, participants had a good level of self-awareness about how the creative activities had affected them, which I thought was very interesting. Many of them reported this sense of calm they felt after and during taking part in the activities, and how this could be transferred on beyond the sessions. So in summary, the effects of this project seem to be particularly strong on confidence and resilience of young people. The environment that was created and around the arts activity seemed to be a particularly strong factor. They were able to link their creative activities and their emotions, and they felt reassured and supported more by the people they'd worked with and who'd worked with them. The second project I'd like to talk about is a music project we're running, a strategic developmental music project, which is particularly about children who are vulnerable or in challenging circumstances. And we work with young people aged 0 to 25 facing a range of challenge. The project's got 4 strands. We're working with specific targeted groups of young people. We're doing some development work with the workforce. We're looking at infilling activity where there isn't any, and we're working strategically with the current providers of music education. But the 2 things I'd like to talk about, I was going to talk about the outcomes overall, which are a mixture of social and emotional outcomes and musical outcomes and developmental outcomes for the workforce and for the organisations. So one of the settings I wanted to talk about is called the Esther Community, which is a supported housing setting here in Exeter. It is a hostel for young people who are experiencing homelessness, aged 16 to 25. They tend to have come out of the care system. And we worked with them over 2 years, running blocks of 6 weeks of music sessions. It was very much digital music making. It's there as a sort of house with a lounge, no instruments, none of that kind of thing, very small. So we took in kind of computers and did a lot of digital music making with them. This was particularly interesting in terms of self-expression from the young people. While it was never ever suggested to them that they write about themselves and they write about their lives, they nearly all did. They nearly all used the music as a way of talking about how they felt and the things that the issues in their lives. It was it seemed to be a socially acceptable way of talking about yourself, that for these young people that straightforward talking would not have been. And they seemed to be able to express things through lyrics and through songwriting that they couldn't in any other way. They increased their confidence markedly in that time. Again, this peer pressure business was quite an issue, and at the beginning they were very, very unwilling to put themselves out in front of other young people, but by the end they were willing to share and participate. The relationships with the housing staff was an interesting benefit from this project, in that it could become quite confrontational for the staff. They spent a lot of time having to sort of discipline and tell them off and control, and this was a positive way in which they could interact with the young people and learn about them while they opened up, which gave them ways to talk and work with the young people in the future. The young people's self-belief increased markedly through the project. They felt able to build tracks and able to do what was asked of them musically in the sessions, and that seemed to have knock-on effects outside the sessions, and they were able to transfer it more widely. Often not very overtly, but they did seem to be able to do it. Similarly, we've been working with a group of children in care who attend a group run by youth workers, which is partially social, but also partially to facilitate the County Council's consultation with young people in care. We put some music leaders in to work with that group over 1.5 years, and they did a variety of musical activities with them, singing, songwriting, and some digital music making. Again, for this group, self-esteem and self-confidence was a particular issue. They were very wary of opening up to others and making themselves vulnerable in front of other young people. But the collaborative music making seemed to be a very good way of moving this forward. They seemed to be able to be given tasks within the music making that they then were able to sort of translate further. Again, self-expression was something that this group really valued. It was a powerful way to express feelings and emotions, and it seemed to be a safe way for them to do it through the music that they would not have been able to do through speaking. I've talked, sort of rattled through there a few very discrete bits of projects, but I think it's extremely interesting that even though they're all quite different settings and different pieces of work, there seems to be something specific about being able to take risks and try new things, and that builds the confidence across these art forms. There's something that allows young people to believe they can accomplish things and have a resilience to mistakes, which it can be improved through a very carefully set up arts intervention. And also the thing about self-expression seems to be something that's very powerful, especially within the music that we have done with these young people. And that's something they've reported to us as being something they value through that particular art form. If anybody wants any further information or evaluation reports, we do have them, and we can pass those on to you. Thank you.
Thank you very much, Ruth. Fantastic insight into some local projects as well. Our final speaker, Alastair Macdonald, I'm pleased to introduce, from the Glasgow School of Art, is going to look at participatory approaches to healthcare service design as well, again with that sense of who's the expert was the title, I think, of what you put, but the ways in which participation, co-production can be transformative as well.
Thank you very much, Mark, and Carrie as well for the invitation here. Oops. Just find my... Here we are. Okay, as Mark mentioned, I'm going to discuss the role of public and patient participation in healthcare innovation using visualizations and design. And I'm going to draw from I don't expect you to see this, but I'm just going to draw from 12 years of experience of working exclusively as a designer. I'm trained as a product designer with healthcare teams, where participatory design has been there to a greater or lesser extent. I thought it might be useful just to clarify one or two terms. I hope I'm not too obvious here, but I think it's important that to distinguish a design, which might be the creation of a plan or let's say an architectural blueprint or an engineering drawing or a dressmaking pattern, for the construction of an object or a system, or the creation of that object, whether that's a product or a house itself, from the act of designing, which is a very, for me, a very iterative process. It's an activity which is about bringing things into being. One definition is that designing is artful and scheming in a positive sense. Participatory design is our approach to design attempting to actively involve all the stakeholders, that might be employers, partners, customers, any citizens or users in the process of designing to help ensure that the result meets their needs and is usable. And if we look at the co-design and participatory design are synonymous. We look at the Design Council definition and the Design for Europe definition. Co-design enables a wide range of people to make a creative contribution in the formulation and solution of a problem, and the approach goes beyond consultation by building and deepening equal collaboration between citizens affected by or attempting to resolve a particular challenge. And a key tenet of co-design is that users, as experts of their own experience, become central to the design process. So I would go further and say they're fundamental and essential. So that some of the concepts that might be associated with participatory design are giving voice, involvement, and empowerment. PPI, public and patient involvement. There are different models. This is one by Clive Savary. He looks at PPI in translative healthcare research. This is a model from a 2010 paper where the public and patients the research can be conducted on patients in the public or with the patients in the public by them, or the actual research can be designed and led by the public and patients. So there's increasing empowerment in that particular model in those four categories. One which I like is modelled on Arnstein's, Sally Arnstein's model of 1989, the ladder of citizen participation. And this particular version is adapted from the New Economics Foundation's ladder of co-production. So as you move from the left to the right here, you're moving from the idea of coercion and education, doing to people, trying to fix people who are passive recipients of service, through to doing for, informing, consulting, and engaging, to the right-hand side where you're doing with, you're co-designing or co-producing in a much more equal and reciprocal relationship. And that's the end of that ladder that I operate at. This is a question, I suppose, that annoys the design community. Can designing occur without designers? Well, yes, it can. If we look at the familiar mid to late 20th century model, designers were consulting for others. Very much the current orthodoxy, the paradigm at the moment is that designers co-design with others. So a kind of logical conclusion of that particular trajectory is that co-designing can happen without designers. And as a colleague I work with at King's College London, Glenn Robert, who is the proponent of experience-based co-design, and the success of this particular method with very clear stages, this can be used by staff and patients without designers, because everyone is an innate designer, in my view. You only need to look at DIY and gardening. You know, everyone's an innate designer. And that's been rolled out for improvement across a number of different healthcare services and areas, clinical areas. What I'd like to do is to give you some illustrations of 3 or 4 case studies to look at the idea of participation in the development of interventions or tools. The first one is looking at a physical stroke rehab intervention, which is used in 3 feasibility RCTs. And this is a project called Engage, funded by the MRC. And I think a fundamental question here is, how do you communicate the correct exercise movement to a stroke survivor? If you're the therapist and that's the patient, how do you communicate that? Well, obviously you can use visual tools, and what we had access to was a digital prototype that one of my PhDs had developed, and motion capture technology. And we wanted to explore a number of issues about this tool that would help the therapist and the patient to have a discussion about the correct exercises during their stroke rehab. And so that was a process involving early focus groups with stroke survivors and therapists, various forms of users, all the time developing the prototype, the mock-up, the prototype of what this tool might be like, meeting with local stroke support groups, testing sessions, and technology testing days. So a very iterative process. And through the prototype and the mock-up, we would ask questions. We would say, you know, how should we, how should the figure be in this prototype? This is showing the patient the movement they're making in real time, and the therapist as well. Should it be a stick figure? Should it be a skeleton? Skeleton wasn't a good idea. if you've had stroke, a reminder of what might lie ahead, or naturalistic. The stick figure was chosen for a number of reasons, and then we're saying, should we show the whole figure or parts of the figure? Where should we view this figure from? This is upper body. It's a bit obscure in the presentation here, but this is for arms and torso. Should we show that from the back or from the side or from the top? And if we wanted to put overlay information, there was other information that we could get from the technology about the angle of the leg movement, for instance, or trying to reach a target with your hand or your knee. How should we represent that? So there's a series of a dialogue encouraged through the use of prototypes here, and we could show things like step symmetry, step speed, step length, and so on. And we were able to show where the patient had been at one stage and where the patient was in terms of the current progress. So what we eventually came up with at the end of that particular process was, let's try and get this to run for you, was this is what the patient would see as they tried to move movement. So there would be sensors on the patient and they would be trying to move their leg. This was customized for the individual patient. They move their leg into the green zone because that would be the correct angle for that particular patient. And if I can, sorry, this. There we are. This is from one of the trials, and the patient is seeing what you just saw on the last screen in the bottom. Is projected in front of her, and you can see what she's seeing in the bottom right-hand corner. And what the therapist is able to tell her is that she's hitching her hip rather than getting the knee angle right. So what this tool that was used as an intervention in the trials is the summative it's the summation of a long iterative process of asking questions through the digital prototype. The second case study I'll show you here is in the area of infection prevention and control for healthcare-associated infections, the Vision On project. And here we developed a proof of concept of a tablet-based training device that could be used across the hospital staff through 3 stages of mock-ups and prototypes involving junior doctors, nurses, auxiliaries, and cleaners, because they all constitute the ecosystem of the hospital. So it's very, very important that the participatory design process involves all the key players, because it only takes one transgressor and the whole of your infection prevention control is spoiled. So we took this again through simple mock-ups, through digital mock-ups, and used these as means of asking questions about how to present information. So this would look at the location, the different pathogens we used, MRSA, C. diff, and norovirus, where they were located, how long they lasted after cleaning, when they re-emerged, and how they were transmitted. And again, just to show you a quick clip from a stage 4 prototype. We're asking questions: if we presented information in this kind of way, would you understand where these? We were trying to make pathogenic data. This is all evidence-based, behavioral data and pathogenic data, trying to make this visible in the context of a ward setting. So there's where the spread of norovirus might happen in a hospital setting. The third case study is looking at the design of a nutrition monitoring and management system, and that was ESRC, New Dynamics of Aging project, where we produced a demonstration prototype. And this was about making different kinds of information and data visible. One of the things we looked at was the food journey, and everyone knew a little bit of the food journey in the hospital. When we actually produced a visual here for a workshop, we actually could demonstrate that some food, what was on the plate, the patient's plate at the patient bedside, had come through 3 different sites in the hospital and it ended up together in the plate. So making that kind of data visual in a way that we could begin to work with the stakeholders was useful. Another way of assembling understanding and experience was through a visual storyboard of the patient mealtime. The patient is the only person that really understands the complete experience of all the different staff and all the processes at the mealtime, because everyone has an individual role or task in that. So we created a series of vignettes from an ethnographic study. So it's all evidence-based. And we asked people to, we had a food family representing all the different stakeholders, including older people in hospitals, and asked them to assemble and articulate the thoughts and frustrations in the mealtime experience, and assemble that into a story of what actually happened during the meal. It's another form of visualizing evidence. And there's quite a dinky little animation of the system that we designed here by Peter Bainton, and you can see that on the website, and I'll give you the details later if you want to see that on Vimeo. Plus a demonstration prototype which included that animation, and also an interactive version of the system of how you could monitor patients' food intake during the day to meet their daily targets. So finally, really just a final case study is looking at participants at the very edge of their capabilities. To what extent can the public and patients be enabled to become involved? And a lot of the work that's been discussed this afternoon has been about involving individuals with various healthcare problems. This is the work of one of my PhD students, and now a research assistant, Sandra Naves, where she was designing tools to enable people in stroke rehab to research into their own mealtime experience and redesign how that might be improved. As the mealtime is often one of the highlights, but also one of the disappointments in stroke rehab, because you have texture modified food, and it happens in a medical setting, and it's not social in the way it should be. So she was involving patients through nurse support in the redesign of their mealtime experience, and similarly looking at the designing of resources for people at the end of life living with dementia and their families, involving people with dementia themselves and their families in the design of a care plan guide. What are all the difficult things that you need to discuss and plan for at the end of life, and how do you run a workshop where you actually get people recruited into that and make that a very positive experience? It's quite a challenge. But again, my PhD student did a good job on that. So back to the question, who's the real expert now? Well, Elizabeth Sanders talks about this. She talks about the virtuosos of the experience domain. These are the real people who will tell you about their experiences. Very important to incorporate into your participatory process. And if you invite them into the fuzzy front end of the development process right from the outset, I think what I should say is that the process of participatory design involves, as far as I'm concerned, involving those people right from the very start, not designing something and saying, what do you think about this, but getting them to set the agenda and the criteria at the very start that you're going to work with. So, final questions, just for the provocation that Mark asked for. How people-powered should healthcare innovation and improvement be? Might be one question. The second is, who should decide the level of public and patient involvement? And the third is, will PPI be tokenistic if we don't provide the means to empower people to participate through design tools, the visualization means, and creating the situations for this to actually happen? So thank you.
It might be quite nice to have those questions still up there, actually,
Okay.
to challenge us as well. Thank you very much. Three different, in some ways, challenging papers, but also with a lot of overlapping and shared questions and challenges in relation to participation, engagement, evidence, and so forth. Each of the speakers, together or individually, is happy to answer questions, and we can have a discussion as wide and varied as you would like. If you want to, yes, come this way if you can. Come this way, it doesn't matter too much, but... Oh, yeah, sorry. Yep, okay, yes, people at home can see you preferably if you sit somewhere like that. So, it's open for questions and discussion. Yes, thank you.
In that co-production, so we think that people are safe learning and usage. Just that my experience of working in bands is that they're rather like a family, and that's really, really positive when you feel safe, and people are dysfunctional when you don't.
Yes,
yeah. That came up
Sorry, just before you answer, is it possible to at least précis the question for the people on the at a distance? We don't have roving mics. We have tried to get them. It's proved difficult. If you could just sort of précis the question.
Okay, so the question was about whether that feeling of safety could turn into something else, and whether we had experience of that because of that very closed situation. Do you mean? Yes, yes.
And when you create music, you create families, like artistic families.
Yeah. Yes. I think that came out in terms of the fact that they were so vulnerable before the start and so unsure about exposing themselves, and that peer pressure thing that you get among young people that age anyway was just so heightened by the fact that they had no safety net. And there was a quote up there, I don't know if you saw it, the only thing they ever actually did together was take drugs, basically. One of them revealed. And so the music was the first thing they really had done as collaboratively. It was not destructive, really. We didn't have it tip over into anything unpleasant, but I could see how it was a very fragile situation. Yes.
Yeah.
I just want to thank all three of you. It's really inspiring, and it's just such a lovely event. I'm interested in processes within real-time musical activity, particular moments in that process, and how they carry over in time so that they feed into what happens next. So in a sense, I think I'm interested in what all of you have spoken about. My question is, let's not, or maybe it's a comment, let's not forget two things. One is the performativity of offering when it's qualitative, or when you're learning about quantitative measures, of how those measures feed back in. And I think that's really important, because I think some of the things Daisy was speaking about have to do with, what we might call placebo effect. Really, really interesting how once you know something about your system on music, so to speak, it's part of the complex intervention that you were speaking about. And I think the issues around participatory design are really very much about this. It's action research, because you're creating the social ecology that allows for new things to emerge and new relations and forms of relationality to emerge. So I guess it's just a question for you, how do you see what you're doing as simultaneously about building communities and involving activism and action research through doing the science and the work that we're doing?
Well, I think one of the things for people who didn't hear the question at home, we were talking about, part of the question was about the potential placebo effects and about how you're actually getting at the in-the-moment experiences, and when somebody knows what effect art, music, or whatever is likely to have, if that's going to affect their response. I think this is where it's important that we have a very wide range of types of data that we're collecting and that we're looking at. And there are some of these things like biomarkers that start to have more of an objective side to them. And I think it's important that we have this combination of biological markers, psychological, physiological, behavioral, combined with this qualitative approach, because all of this doesn't really mean anything unless we're contextualizing it within lived experiences. So for me, it's about providing as many lenses as possible onto whatever the problem is, particularly when it's complex like arts, and hoping that the combined approach of those different lenses gives us the strongest possible idea of what's going on.
Yeah, I think to look at your question about social ecology, I think that's very, very important in participatory design, and how you might set up the situations within which people feel comfortable to operate. And also some of the hierarchies that you might find, say, in a healthcare setting where you have the clinicians and then the senior nurses and the auxiliaries and then the cleaners. The cleaners at the bottom of the pile, actually. But you can look at the worst offenders in hand hygiene, like the junior doctors. So how do you deal with the kind of power politics in that kind of situation? How do you empower all individuals? How do you provide what in the Scandinavian areas, the research called infrastructure? How do you infrastructure that situation? How do you create the publics, the setting within which the activities of designing can actually happen? They're very important points, yes.
That is more of a comment too than a question really, but I think they were an interesting family of presentations because they looked at the same thing from different dimensions. And I would suggest that the word intervention is soon going to become redundant, because of course the natural evolution of what Ruth and Daisy were talking about is that actually young people themselves will be empowered in the jargon and the source to make music themselves. Mothers will be encouraged to sing to their babies or with each other. And I wonder how all of you in your different ways see the future developing towards a truly independently from the ground rising up artistic world in which people see art and healthcare as in the same events.
I think you touched on a really interesting behavioural aspect there, which is at the moment, as you say, we're often having to talk about interventions where we're saying to people, there's evidence this could be a benefit for you. And I think part of the reason we're still having to do that is because this is, whilst it's an old field, it's still relatively new that people are talking about these kinds of things. So I feel that until there's very strong public understanding about the benefits of arts, culture, design, all of these things on our health, it's going to be important that we're still encouraging people to make the most of these, because they don't always seem like the obvious things for people to turn to, particularly when people are used to medicalizing a lot of their problems, including things like loneliness and going to the GP. And so I think we're still going to be forced to use some of that language for a while until it becomes commonplace. But what I think is really promising is that a lot of the ideas for projects and for community engagement are very much coming from the ground up, often from artists themselves, who are often got the keenest insight into this because they've seen day in, day out the effects their programs are having. So it doesn't tend to feel as though these programs are always being designed from the top down. I think there's a very good level of co-production in arts and health participatory activities like arts and music programs. But I feel that it's always going to need that nudge of encouragement until it simply becomes, I guess in an ideal world, it would become commonplace where people know when they feel low that they should be going and joining their choir, or they recognise that they might be having low-level mental health symptoms because they've not done anything creative for a few weeks.
I completely agree that it's always got to be the aim that people take that on themselves, that they work out for themselves what they need and drive it forward for themselves. I suppose I would comment that we have found in our experience that the more vulnerable people are, the less likely they are to be doing that for themselves, and therefore in an ideal world, yes, but at the moment, definitely just to push things towards those that need it, it does tend to be a case of having to actually intervene, I suppose.
Yeah, I would just kind of add there that we wouldn't talk about intervention with the user groups. We would talk about something like communication aid or whatever. But if your funding is coming from the MRC and you're running a control arm and an intervention arm, we tend to use that jargon for the sake of obtaining funding.
Can I just I will ask a slightly sort of technical question, but when we talk about music, it could be the singing or it could be the music. How do you know? Is it the participating in the music, which is what I think it is, or the participation in the singing that is having the effect? I know you talked about having the audience there one night and that sort of performing business there, but could you just be an observer and be listening to the music or experiencing these other people sing and still have a benefit? How do you tease out what it actually is? I mean, my hunch is that it's the actual participation.
Well, when I showed the that diagram earlier about the personal, physical, social, and musical aspects of the intervention, I think what I found from studies that sometimes where we've directly compared these things is that even very passive engagement, so for example listening to music, still has psychological and biological responses. So you've not got to be taking part. But it seems to be a bit like an additive model. The more of these components you've got in place, the greater the effect seems to be. So we've actually had studies where we've directly compared listening to choirs and singing choirs. And the people who, you can see benefits from listening, but you see stronger benefits from participating. So as far as I'm aware, it always seems that the more you're engaged, the more benefits you seem to get from it. But that doesn't mean that's always possible. And a lot of the settings where we're developing these kinds of programs, like the use of music in surgical settings, there's not really the option to make it participatory. So therefore, you're always working with whatever context you have.
Well, just very quickly, why did you think going to the cinema was very effective?
Well, I have actually done some other analysis looking at television watching, and unfortunately setelevision watching seems to speed cognitive decline in older age. So you're okay up to about 3.5 hours, but beyond that. But
is that cause and effect? Is it because you haven't got the initiative to go and do something else, and so you just sit in front of the television?
Well, even when you take account of all those other factors, like whether people are socially engaged, whether they're culturally engaged, whether they're involved in any clubs, hobbies, all those kinds of things, the effects are still there. So they explain a little bit of it, but not the full picture. So what I wonder is that we've had quite a lot of evidence in children about the effects of screen on things like cognition. So I'm wondering whether cinema as a composite of a screen-based activity and a cultural activity perhaps is the screen element, which is a very strange thing for our brains to cope with. It's simultaneously very fast flashing images, so it's very active, but it demands no involvement when you're watching. It's a very passive activity to do. So I think because cinema can be a little bit like television in some respects, I feel that sometimes the benefits you might get from other types of cultural engagement, like the social aspects and the cognitive engagement, you're not really getting. I haven't done any studies of virtual reality yet, I'm afraid. But interestingly, we've found that internet usage in older adults actually supports cognition, and that might be because it's more active. You're having to click through, you're having to make decisions. When you're watching television, the only decision you've really got to make is what channel you're on.
Gary, is there somebody on?
Hi, yeah, I've got a question. Niels has put his hand up. I'm just going to unmute and see if I can...
Type your question.
If you could just...
Yeah.
Niels?
Thanks, Chair. No. If you can ask him, can you ask him to type his question, or we can relay it in some way, Gary. Other questions?
Yeah, I think I also echo the previous and really good set of talks. And I think I was in medical school and we would work on singing in stroke issues, group singing in stroke issues actually. And I think one of the really interesting things, fascinating things about singing and music more generally is when it's delivered in a group setting, it serves to bring people together quite rapidly in ways that possibly other kinds of interventions don't do. So for me, whilst there are benefits, clear benefits of singing and music making in and of itself, actually I see singing and music making as a vehicle in which we can deliver other aspects of healthcare treatment. And so it's not a question. So I think although I do think it's really interesting to see that some of those stronger effects that you seem to be reporting are about when people are together doing it with other people around. I think that's what you used that idea that it's largely about connection, facilitation.
And I think that's really important. Sometimes people think that it's a weakness if we're saying that actually it's about the social element that's particularly key. What I would say is that some studies we've found, like with the postnatal depression study I mentioned, we weren't finding the benefits from the social alone group. So there were things about the singing group that seemed to be particularly key. But broadly, I agree with you with the word vehicle, in that if we know that music is a particularly effective group bonding activity, and that's being compared with a whole host of other types of interventions. If we can see these benefits that you get from the arts and culture, for example, the fact they're simply very enjoyable to do, and if those are enjoyable and accessible ways of getting people to have these other benefits, like the socialising, then we should be capitalising on that and seeing that is one of the real benefits of arts and culture.
Just to repeat, thank you for the talks. The nice thing about having them all together is it makes you think about the kind of overarching schema. And one of them I thought about, I think, when you put up the ladder, and that kind of sense of the distinction between design-led and then ground-up. I just wonder whether, and one of the things we've been doing in the centre recently is reading Dewey's Public Problems for various reasons. One of the kind of interesting things there is the kind of the way in which you constitute the public is how you mix the abstract together with the intimate, is the kind of issue. And all of the papers in some ways had that sort of sense in which biomarkers were mixed with the intimacy of performing or experiencing things, designing, you know, there's the abstract job of modelling the way in which we move and allowing instant feedback for people to kind of take that into their intimacy, experience of themselves, seeing themselves differently, etc. And so I just wondered whether we can do better than that ladder and think more about how we network together. You know, there's something more multidimensional than design or, you know, top-down or bottom-up. There's more of how do we go about putting things together in order that they're constituted and generative of something new and exciting, rather than that kind of, what we seem to have inherited is that distinction between modernist top-down led versus a kind of populism.
Yeah.
I suppose behind all that, I will get worried about the populism because it feels a little bit like we're the expert, and I think we do need experts in some of these fields, and all the papers have suggested that.
Yeah. Well, I think there's another dimension to the participatory process which I didn't really discuss, which is actually getting all the different disciplines within your research team to work together as effectively as you can work with the public and patients. In a sense, that can often be problematic. It can often be very productive, but it can also be problematic as well. So I think it's not just about the stakeholders, but the experts that you involve in the team that need to be part of that particular process. So I would agree with that. I think the other, I suppose, as a designer speaking here, that one of the things we're very conscious of is that when you talk about something, each of us has got a separate mental image of what the other person is talking about. And I think one of the things I often say is, show me what you mean, you know. And in a sense, you know, if you were developing a digital tablet training device, you know, you want to kind of say, well, is this the kind of thing that would be helpful? So you're trying to have a dialogue with the material, although it has been abstract in everyone's heads. You know, you're actually trying to say, is it a bit like this, or this, or a bit of that, and a bit of that? You know, show me what you mean. You know, to give people the tools in that kind of situation to express in a material way. I'm not sure if that's answering your question.
No, it does. But I think I'm sort of more folding back to what you're all actually doing. Rather, you're not doing ground up or top down. There's actually that continuous process of manoeuvring. And I can't remember the lovely word we had for designing was seemed to capture it. The scheming, yeah. Scheming is much more interesting than that ladder, I think. With the schematics and a kind of process and a learning by doing that you're all learning together. In the more environmental field, which I'm more involved in, we start to talk much more about competency groups, which feels like you're kind of together forming something, a group that can tackle a set of issues. You know, it works for that.
We'll try. Is that Neil's?
Yeah, he's actually typed his question. So his question is about scalability. He says there seems to be some tension between the individual, people-centred nature of cultural participation and the ambition to demonstrate that there are universal benefits. So the question is it feasible to demonstrate that an arts and health intervention is effective for everyone, or is the hope to demonstrate on a more general level that cultural participation has a benefit on health?
I feel it's actually both of those things. So I feel like there are two angles on this. One of them is about how general participation in our daily lives has health benefits and what those benefits are. And that's hoping that that's something that technically should be available for everybody and everybody could be benefiting from. But then the other angle on this is then picking on specific groups. So people, for example, with a particular health condition or from a particularly challenging background or with a particular barrier to access, and recognizing that these people are special cases and that we need to identify particular types of programs that can either be used to draw them in if they wouldn't normally engage or could be particularly targeted to their needs. So I always feel we need to have this dual level in terms of the kind of art for all approach where everyone should be able to engage in arts and culture and get the benefits, but then the targeted approach for those people who aren't going to be able to do that. And those people will be a smaller percentage, but they're people where it's important we're also focusing our resources because they're not going to be catered for by the generalist approach.
Thank you. Daisy here. Question kind of going to be a bit reductionist actually, which is not my style, but it feels right. Because the question is about that there being equivalent studies for matching the same condition and the same biomarkers and using medicine or drugs in a way that actually is usefully comparable with the approach that you elucidated in our arts interventions.
Yes.
You can use quite specific targeted indicators.
Yes, there have been some of these.
Kind of whether whether we begin to be able to say that £50 a week arts intervention is more effective than £500 a week clinical.
Yes, so I've got a couple of examples. One of them was been looking at the use of music in pre-surgical settings, and there was a directly comparative study a few years ago that looked at benzodiazepine versus music and actually found that having music pre-surgery was more effective at reducing anxiety and was cheaper than using the drug approach. And that was a really nice comparative study. Another program, which is much more of a participatory program, is run by Breathe Arts Health Research, and it's called Breathe Magic. And this is a program for children who've got hemiplegia, so that's one-sided paralysis. And normally the recommendation for these children is they do between 60 and 120 hours of intensive physio on their hands over a 2-week span, which for a child of 7 years old, that's almost impossible to get them engaged in such a heavy load of physio. But it's been shown that when you can get children to do that, the improvement in their hand function is like a step change up. But what Breathe Arts Health Research did is they took the medical model, which was called Habit, this particular training program, and they turned every exercise, they worked with the magic circle and turned every exercise into a magic trick. So instead of going on a hand occupational therapy physio 2-week intensive program, you went on a 2-week magic camp. And you learned to do all of these magic tricks, and the kids had no problem practicing a magic trick 50 times in a row. And what they also found was that there were other benefits from this. So because it was focused on being a magician, you also looked at things like eye contact, communication skills, all things that children with hemiplegia, many of them had cerebral palsy, they were often much shyer, they had much lower confidence, and they were used to being the child that couldn't as opposed to the child that could do something. And there have been several clinical trials now of this program, and I sit on the board for this organization. We've run lots of studies, and it's actually been shown that this is more effective than the previous Habit approach, and actually it's completely comparable cost-wise. So several clinical commissioning groups around the UK have been commissioning this instead of the other approach because it is, as I said, directly comparable and more effective. So yes, fortunately we do have some of those studies now coming through.
Can I just follow up that question and perhaps go back to some of the other questions as well, Ruth, and ask you? Because it doesn't seem to me in a sense that you are necessarily dealing with health problems. And this is quite interesting. I know you are in some ways, but I wondered how you got into music, health, well-being in children, because it seems to be much less directed towards resolving a particular health challenge, and much more about encouraging self-confidence, encouraging well-being, encourage connections. And then the question about whether it's comparable with another form of intervention is quite different, because there probably isn't another intervention. There actually isn't anything to compare it with, because it doesn't seem, this is going to sound terrible when I say it doesn't seem to be clear that you know what you're doing, in a sense, because anything can emerge from that process, which means any kind of comparison with conventional medical approaches becomes meaningless in some ways. Is that?
Yes, I would say, well, one of the projects that I talked about was very specifically looking at mental health, but the other one, very much so, the outcomes range was very broad, and it depends who you work with, what comes forward, and you then work with what the need is that arises in the room with the person. So you're not targeting in that way, so that, as you say, that you can't imagine a parallel kind of healthcare. Yes, the music one was very much geared at musical skills and positive self-development. What came out in those particular settings that I brought forward were these particular kind of confidence and resilience issues around mental health.
Sorry, one Arthur.
Yeah, I'm going to ask an annoying question for arts and health people. I know it's annoying because it annoys all the people in my project. And that is, what do you see the role of aesthetics in, what is your, in fact, it's of each of you, where do you see aesthetics fall into the question of arts and health? And particularly, like, for example, maybe a reductive version of aesthetics, but what do you understand by the role of aesthetic judgment? And the reason why I was thinking of this is because, to play on Daisy's example of the cinema, there's a really interesting form of aesthetic conversation in aesthetic theory about the notion of spectatorship as being related to the theatre as opposed to audience, which is related more to the cinema, and it's to do with active participation, that you are more actively involved in a theatrical performance than you are in a cinematic performance. Not simply because you are seeing with the one spectator versus hearing with the other audience. But there's also a sense in which cinema is obviously, as people have said in aesthetic theory, a desiring machine. Much of what the arts is, or how arts works, is in creating lack, in a kind of a sense that you don't have something, that you need something that you didn't know you needed. And in some ways that seems like it could create negative health outcomes as much as positive health outcomes. So I guess the question is not really to, as I've done, show off what I know about aesthetics. It's more to ask you, or challenge you, to tell me, what do you see the role of aesthetics, if indeed you are as interested in the arts as you are in health?
I feel I should stand up for the film industry a little bit at this point. I haven't found benefits for cognition and well-being, but there might well be other benefits from going to the cinema. I think one of the things that I've been involved in some studies is we've tried to directly compare if people have had a choice in what they're engaging in with if they're being given it. And I'm sorry I can't see you because of the screen. We have been trying to see whether if they have a choice in it, it gives a better result. And actually, interestingly, we haven't found that. We've not found that having, for example, a choice of what music you're listening to in a pre-surgical setting, it doesn't seem to improve the results from what we're seeing psychologically, biologically, behaviourally. There has been a big debate about whether something has to be good art in order for it to have benefits. I think this is something where everyone has a different opinion. My personal opinion is it's not necessarily about a good art output, it's about a good quality art process. So if you're engaging in something which, for example, is a very high quality dance intervention being led by good dancers, that's what matters much more than whether you yourself end up being able to put on a good dance show at the end of it. But these are quite sort of, I get your point, these are quite challenging issues to look at. I'll be interested to see if there are any in the design
well,
area.
I don't measure aesthetic response, but as a designer, I suppose I'm aware of 3 different categories of aesthetic response. One is those which are hardwired into us, like a bad smell or a sudden movement that might be a threat. Those that come from our personal experience, so we associate certain things like a smell or a sound with a particular period in our life. And those which are kind of culturally developed. And I used to use an example a number of years ago when you had the Sony Walkman and you had a light, thick one and a thin, heavy one, and you asked which people what had the best quality, and they would always say invariably say the thin, heavy one, because that was about technological density. So it's aesthetic response from a product designer's my point of view, would be the intersection, the awareness of those different kinds of responses, which are all coming from different directions, hardwired, your personal experience, and cultural conditioning.
Steve.
Thank you all for really interesting talks. I just wanted to ask, when we've always known that arts and music and healthcare are good for us. That's not a new thing. I mean, we've been talking historically about choral bands, dance, that kind of thing. So those things, we've always known that these things are good for us. So why is it that people like policymakers seem to have forgotten that and now seem to be needing to be re-educated? I just wonder if you could kind of comment a little bit on that.
I don't think it's a re-education. I think, as you say, people have been aware of this, but in fact, if you look back at the kind of history of policy documents in this area, which I had to review pretty much every policy document that's ever been written on this when I did my book earlier this year, and in the UK we've had a big sort of surge of interest, mainly from the 1990s onwards, and you can see these pivotal moments where you can see particular individuals often have spearheaded a conference, policy report, a white paper, and that's sort of been the next iterative step forwards. I think the reason that we're now hearing so much about this is that there's been this sort of convergence of the increasing number of times that the arts and culture are being cited in health papers and also in arts policy papers. But alongside that, there's also the changing needs within the health sector, increasing focus on things like public health, on drawing other sectors like education, like social, like communities into conversations on health, and also a growing recognition that we have to find alternative ways of supporting health with things like budget constraints. So I feel it's been this parallel increase in policy documents and also increasing need from the health sector that's meant that we're now having so many conversations about this. I don't think there's ever been a period in history when there's been a better understanding politically about this that we've lost. I think it's more that now seems to be a particularly good momentum, and I think things like the All-Party Parliamentary Group for Arts, Health and Wellbeing and their political inquiry, that's been a big strength for the sector in having that happen, and I'm pleased that they've got an extra bunch of funding now to actually try and follow through those recommendations, because of course always the fear is that you have this increasing momentum, but then you miss individuals, you're missing funding, and it kind of goes away. But at the moment, I'm not too worried that it's going to disappear, because I feel like it really is building in the right direction.
Is it because there's more evidence too that can be that can talk to the healthcare community?
Yeah, I think that's probably a very good point. We've got an expanding range of types of evidence now, which means that everyone's convinced by different things. Some people want case studies, some people want numbers, some people want ethnographic approaches, and we're generally able to cater for all of those now with the evidence base that exists. So I think that's a real strength.
The healthcare system being so evidence-based, I just wondered if that was a key part of being able to evidence why it's useful.
Yes, and I also think we're seeing arts organisations like Breathe that I mentioned earlier now being able to put forward very compelling business cases to clinical commissioning groups and understanding the process of how to write those business cases and what things are needed to convince commissioners. So I think there's been a lot of learning around the business angle of this as well from the arts sector.
I was going to expand on the comment about Daisy's presentation and the evaluation of it. You may well not find a measurable health outcome, but you will almost certainly find some sort of outcome in relation to its employment, contacts with the criminal justice system, and all of those sorts of things. And one of the sadnesses is that health looks at these health markers or well-being markers in its own little silo. Criminal justice looks at them separately. and often the twain don't meet, which seems a great loss because there will be definite measurable impact.
Yes, yes, and definitely the crossover between the the groups where you look at children in care and then you look at mental health and youth justice, and they're all seen separately, but actually the crossover, as you say, is phenomenal.
Firstly, thank you. Fascinating discussion on social presentations. I am a professional musician, but also working humanities research and research. And I'm quite fascinated by two questions that have touched on things that I've been thinking about. One was in relation to whether, essentially, arts participation has become a norm, whether it would have a general beneficial effect on the population as a whole. Tempered by the question about aesthetics and potential negative effects of arts participation. And I think there's probably a distinction to be made between arts participation in the community sense, in the sense of, I founded my first choir when I was 15, and I'm quite strongly to believe that almost everybody should be a choir. That's simply for the experience of it and social engagement and creative engagement that provides. But I don't think it's the case that necessarily everybody who joins the choir should want to become a professional musician or a composer or something like that. And the people who go on to find the arts and music to be the centre point of their lives and in an aesthetic sense deal with very deep degrees of criticism, self-criticism, extreme demands on technique and creativity, knowledge and things like that. I think there's a distinction to be drawn between musical engagement that is communal, health-based, and essentially a community engagement, and then it's a professional element, which is very much more about testing the edges of what is socially acceptable and possible. And so I find that quite interesting. I think if you look at the professional music industry, you probably find people who, through music and that experience, very deep depression, very complex things in their life. But also teaching music to people and teaching instruments to people. I've often found that the most complicated people to teach are those who are most technically competent. And so their demands of themselves eventually stop them from progressing. So they become aware of their musical potential, and their knowledge of their musical potential stops them. And quite often they give up. It can be one of those deeply frustrating things. But at the same time, if you go and work with community work, very often the transformation that people experience simply through taking part in music, possibly for the first time, is one of the beautiful things about it.
I think it's a really interesting point that you've brought up the professional angle on this, because sometimes what we've found from studies is that the benefits that you might get from engaging as a hobby or as a fun activity, you don't really get so much when that's your way that you're trying to earn your money, and it becomes the sort of one of the focal points of stress in your life. So I think professional musicians and professional artists, you can get this kind of flip side. But I also think it's really valuable for the arts and cultural sector that they are looking at engaging in this sphere around arts for social benefits, arts for health benefits, arts and criminal justice, because not everybody who goes to, for example, a conservatoire is going to end up performing on the Wigmore Hall stage. And if you imply to artists, musicians, that their aspiration should be about being the best or achieving fame in that way, then not only are you setting them up for failure, but you're also very narrowly putting them into one type of activity they could be doing. And actually, lots of people study the arts in order to become teachers. But I think what we're now seeing is that lots of people can study the arts in order to go into careers that are working in health, social care, criminal justice. And often we find that when people do this, one of my colleagues has done quite a few studies when we've done these interventions, focusing on the artists and musicians who've been leading the project and seeing the benefits for them. And they can be huge. They can get almost as much benefit as the participants can. So I think it's really important that conservatoires and arts colleges and the arts sector in general are looking at this as a very viable career option as well, not just as something that they're giving back to the community. I think the benefits go both ways.
Yeah, just in response to that, I run a charity called Upstream, and we've been delivering community arts projects in the Mid and East areas for the last 15 years. And I'm interested in this idea of the aesthetic, because over the years we've run projects with professional artists and with my staff who are just community members. and quite often the aesthetic will stifle the community aspects of the group, which are the social benefits. And I think quite often what we found is that the groups that are run by non-professionals, their life extends over a lot longer period of time because they've really focused on group cohesion and all the social benefits rather than just producing something artistic or aesthetic. Although that's the purpose for being there. But I think it's looking at how we facilitate those groups. Again, you can put an artist and a group of people together, or a musician and a group of young people together. It doesn't necessarily mean you're going to have great outputs. So I think there are skills involved for facilitating social connections that don't necessarily get looked at. It's a different layer of skills, it's not necessarily being a professional musician or professional artist, but it's that social cohesion and managing the group so that people can feel valued, and that involvement and that empowerment is an integral part of that creative process. I think we need to focus on that just as much as the artistic part.
Yeah, I think it's very heartening. We're seeing lots of training programs developing for artists and musicians in order to work in these environments, particularly when they're looking at working in challenging environments like in hospitals and things as well. So I think it's great we're seeing the professionalisation of what lots of artists and musicians have been doing anyway for a long time.
Back there.
That's what really value what you said there about the process being the end point in a way. It's not art. I really get that in the whole setting, but I think we have to talk to you as a designer and someone with an arts a keen aesthetic sense, I suspect. I know designers who lament they no longer use Photoshop. That actually designs become so functional, even in people in a commercial environment. They don't even have to think about the aesthetics of what they're producing, and they're doing sort of that design. It's not done very much. It's not coming to the picture anymore. And we're talking about design interventions, and just wondered, there's a lot of opportunities for healthcare. But what about the threat to the aesthetic for developing things for healthcare? If we just look at that function.
Yeah. So the question was really about the threats as well as the opportunities from around aesthetics, from things like Photoshop, the kind of prevalent technologies that we might have access to.
One of these cultures, as we are becoming more functional in our approach to designing stuff anyway, designers are becoming more functional. That's something where people are less likely to really concentrate on aesthetics as time goes on, it seems. Yeah. And I'm just wondering, as that's being lost in our cultures, that's being lost. Yeah. How do you see that playing out in terms of?
Are you suggesting that particular tools that we are given, whether it's Photoshop or whatever, actually create a form of aesthetic? It's kind of interesting who decides. If I take the example of the training device that we did for healthcare-associated infections, that's quite interesting. One of the very simple things we did at the very start, I did a hand-drawn ward layout, just very simple. No technology involved, and everyone could really interact with that. They could draw their route through the ward, had no kind of conscious aesthetic about it. When I got my software engineers onto building the virtual ward that you saw the clip of there, they kind of really defined the look of what the tool should be like. They had their own kind of software engineer approach to the design of that. So they were determining the aesthetic. That might not be the. It had a kind of quasi-realism about it, and there was this kind of drive to make things more and more realistic and show the clutter of the ward. That kind of that is an aesthetic as well. It might not be an attractive aesthetic, but that is the aesthetic of the ward. Is all the paraphernalia around the patient bed. But I suppose that I'm not sure if I'm understanding your question, but I suppose a question for me there is really that that kind of aesthetic thinking, that kind of way of delivering that virtual ward might not be useful functionally if the function is to communicate the intent of that particular tool, which is about how people interact in that ward environment and how pathogens are transmitted.
I think this one is about, I'm working in medical school, so it's all about efficiency, cost saving, and getting the most effect for your money.
Yeah.
Okay, so there's
yeah, I think I get you. Yeah.
Do you get me? And whereas art, it's not necessarily about it's a different space, isn't it? It's not
Well,
necessarily about.
Well, it's interesting. I was having this discussion with a colleague last week about the actual plan of a hospital ward is an economic and management diagram. It's not a diagram of care. So, and this is very interesting because I'm involved in a stroke rehab study, and one of the drivers in hospital design is to create single bed rooms. But when you're actually in that might be okay for short-term acute. So that's one of the drivers is cutting down antimicrobial resistance. But what some evidence is showing that there's a kind of maybe a complacency develops because the single room is meant to cut down the spread of AMR. But also it doesn't serve longer term stay home, if you're in a rehab for stroke, because you need much more social interaction, and it mitigates against that. So if I'm picking you up correctly here, that the diagram of a hospital ward is really a management and economic diagram rather than a care diagram. One could propose. So that creates an aesthetic in itself of the long corridor, with the rooms off and fewer social spaces.
I guess what my question is with the opportunities that arts have to offer healthcare, is massive.
Yeah.
Do you run the risk of artists and compromising to the point where it's not really what it could be? It's a kind of, it's like a compromise.
I've had to do it there.
I guess that's always the risk if you're saying that you're trying to identify a health problem and then you want the arts to solve that problem, and you're going to do it in a very sort of narrow way, but therefore it's not really very artistic what you've ended up with, and it's sort of a bit of a compromise for both parties. Yes, exactly, a functional as opposed to an enjoyable artistic experience. But I think that's a sort of poor application of the arts to health. And the thing is, you can identify specific health challenges and you can try and come up with artistic solutions, and that's a really nice way of working. But the good projects are the ones that don't just try and solve the particular problem. For example, with Breathe Magic, they weren't just trying to solve the problem with hand function. They also recognized that magic tricks have got all these wider psychosocial benefits. So why not make the most of those and not just make it about magic exercises, but make it a whole magic camp with a magic show at the end, even making your own magic costume. And I think that's the much better approach. Yes, it's solving a health problem, but it's really capitalizing on the creativity of the arts in doing so, and therefore having a bigger impact.
Yeah. So we go to no, okay. One at the back there.
So one of those my questions are very clear. I just wondered if you had any comments on how this will fit within a wider background. How we use culture, how we use arts to change over the years, and how our sense of community change over the years, and how this affects our mental health. And the changing problems and issues and things that come with our sort of changing society. And I don't know, maybe a thought that I had was relevant to this is kind of our knowledge of things that placebo effect, and if we know more about the placebo effect, and then people think, oh, if it's a placebo effect, their ability to that's the kind of side shift, their ability to get actual benefit. I don't know. Sorry, so it's not very clear, but just putting it within a wider sense of how things have changed over time.
Well, I expect that you'll have something to say on the educational side of this, but I think something that we're certainly noticing in society is that we've got a lot of issues around things like loneliness, partly because things like internet, phones, mean that you can communicate without having to have the social contact that you had to have a few decades ago in order to get that.
And yeah, the relationship with technology.
Yes. So I think a lot of the things that we're seeing now, where it's the benefits of things like being in community choirs, these are things, we've had community choirs around for tens of thousands of years, arguably even longer than that. So these aren't new concepts, but they're things that I feel is an increasing emphasis on maintaining in society, because we don't need them. You could sing from your own bedroom, you could sing online through YouTube. There are lots of apps that you now sing live and stream it. You don't have to get out into the community to do those things. But I think a big challenge is trying to find ways that we can encourage people to continue to be engaged in their communities, because there are so many benefits they get from that. So I think that that's a nice opportunity for the arts, is to keep making their case beyond things like technology and keep telling people that these are positive things they can be doing for their health and well-being. The arts are a really good vehicle for them. Yes, you might be right in that some of this stuff that we're arguing isn't anything new. It's about maintaining or reinvigorating old things.
Yeah, or revaluing.
Yes.
Yeah.
Yeah.
And it's also that. Sorry.
I think you often have to re-argue for the case for things. And I was thinking about in the education context, a lot of the creative things that used to just happen naturally in particularly in primary schools, have been hived off into kind of maths, literacy, and then you have your art and your music if you're lucky. Whereas before it was spread much more and seen much more as the education that any child should have. So you have to keep re-arguing, I think, to keep it within what used to be kind of natural education process.
If you read policy documents from the Arts Council, it's a very interesting trajectory over the last few decades, where things have moved from being about art just because it's nice to have art around, through to art actually having to make a case for itself as some kind of business that has a social return on investment. And I think now we're starting to look at this kind of health return on investment. And obviously we have to speak the language of policy as it evolves, but I don't think that we should just be seeing it as art having to make its case in order to exist. There are obviously benefits just from having art anyway, without it having any particular purpose. But I think it's an interesting trajectory, and I think an important thing for the sector is trying to stay on top of that trajectory, work out where it's moving next, and make sure we keep staying relevant to that agenda.
That kind of answers my point. I was thinking along the lines of engaging with policymakers and what your experience has been, and it sort of follows on from Felicity's question and Colin's question about how have you found the best approach in terms of, how do they engage? Is it by saying we can save this amount of money, or is it that we can have these benefits?
I think I've always found that the best way of engaging with the policy side is to make sure that what you're proposing, you're talking about, is strategically aligning with their priorities and their strategies. So, and I think this is sometimes a challenge, because some people have got great projects that they think should be being funded or should be being commissioned or whatever, but if it's not something that's strategically relevant right now, then they're going to be kind of hitting a bit of a brick wall. So I think the strongest approach for arts and health is to try and identify what the major priorities are, whether that's, for example, mental health, or it's issues around isolation, loneliness, or whether it's particular health conditions, and look at how the arts can support those particular agendas, make the most of them to make sure they're staying as creative and fulfilling as possible, but try and make sure that we're trying to support policy rather than demand things from policy.
Yeah, one final question. Thank you.
Thank you. Lots of things I could say, but just taking that up. I've worked in mental health and health as a social worker, and set up several projects. And what I was going to suggest was that actually engaging with practitioners, because they're in touch with people, and to make another comment on the aesthetics and the process and product element. Running a group, we set up a group for people with long-term mental health problems, and we engaged an artist, got Arts Council funding. It wasn't difficult in the 90s to get Arts Council funding for these things, and we engaged an artist, and we worked with, as practitioners ourselves, myself and an occupational therapist. We joined in the group, And it was a whole great experience for all of us in growing and understanding and learning. What we put on an exhibition, people were amazed at the quality of the work. It really was some superb work. People had learned through working with the artists. But what stuck in my mind was that people said, actually it's doing it that matters. It isn't really what they're producing, it's doing it that makes all the difference.
I want to ask you, I mean, I could ask you, but you've spoken fantastically, and that's a nice point to end on in some ways. It's not the winning, it's the taking part. That's rubbish. No, it's really important, you're right. We have learned that you can have design without designers, we can have music without musicians, but we cannot have a seminar without speakers. And we are very, very grateful to all three of you for stimulating, provoking, fantastic discussions. So thank you very much. And if anyone's interested, the next seminar is sometime in December. Kerry? December the something? Yeah, that's right. Anyway, we have another seminar at some stage. Yes, yes. Send it round. Okay. Do you want to shout it out or not? People may have to go, that's all. There are places to go and things to do, and planes to catch and trains to catch. So maybe we'll chase that up at some stage.
Yeah,
Kerry?
it's a message for us.
Okay, fire it at some stage. So thank you very, very much indeed. It's fantastic to see you all, and we will see you soon. What's this, Jill?
This is the list of email addresses. So if you don't have your email address and you do want to be on our mailing list, please make sure that you sign it in.
But could you sign it anyway? Just don't be very email address.
Sorry?
Do you mind if I just say,
No,
if
no,
anyone's
no.
interested,
No,
I've got
do.
discount vouchers for my book if you wanted
Ooh.
to find out more about arts and health.
Very wise. Thank you ever so much. That was fantastic,
It's
Alistair.
really interesting.
Absolutely
Yes,
fantastic.
that's so
Stimulating
interesting.
in lots and lots of ways. All of you.
Like, you know, mutually too, yeah.
It sort of worked in a way that we weren't quite sure, to be honest, what would come out of it.